A very good morning to everyone. Today, I would be speaking on IOCT guided glaucoma surgery. At the outset, I would like to thank AIOS for giving me this opportunity and also thank my mentor and guru, Professor Tanuj Dada, for believing in me. I am Dr. Dewang Angmo, and I would be speaking on IOCT guided glaucoma surgery. I have no financial disclosures to make. So introduction of OCT into clinical practice has brought a landmark change in clinical diagnosis, management, and monitoring of nearly all ocular pathologies. On the same lines, OCT integrated with operating microscopy has also brought a paradigm shift in ophthalmic surgeries. The feasibility of OCT was first described by Ehlers et al., and ever since its use in ophthalmology has evolved. During surgical maneuvering, the IOCT with heads-up display allows rapid visualization of the area of interest and provides with information regarding the surrounding tissues, regarding the tissue itself and the instrument-tissue interactions. So today I would be covering IOCT-guided bleb needling, IOCT-guided bleb-sparing epithelium exchange, IOCT-guided transconjunctival suturing, IOCT-guided bank cleft visualization, IOCT-guided AGV tube positionings, especially in corneal opacities, and OCT-enhanced aqueous angiography. So the first is IOCT-guided bleb needling. As we all know, bleb needling is a blind procedure, and wherein a 26-gauge needle is inserted into the bleb and needling or cutting of the fibrosis is being done. However, with the advancement or with the introduction of IOCT, we can directly visualize the depth at which our needle is going, and therefore the inadvertent damage to the underlying sclera, like scleral perforation, uveal tissue prolapse, or hemorrhage has now been negligibly to, in fact, minimally to zero. And this is, we can see a patient in which there's a flat bleb in vivo at baseline preoperatively, and the same patient at the end of the surgery, we can say how well raised the bleb is, because after the going into the right plane and doing the fibrosis, dissecting the fibrosis, the aqueous has flowed out, and we can see these well elevated microcystic bleb. And because of its finer resolution, the OCT is able to present a detailed view of the bleb wall, underlying sclera, and an accurate assessment of the bleb and the extent of the bleb structure. So this is a small video clip wherein we are doing, we can see the flat bleb. So this was a case of post-traumatic aniridia along with operated VR surgery. And patient was unaffordable for the valves, so we had to do a trabeclectomy, and as known, it failed. We can see that there's a flat bleb to start with, and we are doing an endo needling, and as we are cutting the fibrosis, we can see that the bleb wall is also increasing, which indirectly means that there is a direct aqueous flow from the anterior chamber into the bleb wall and posteriorly. And in the same OCT, we can see that the bleb wall is now actually well raised. It is well raised, and it has multiple cystic spaces, meaning that the aqueous is flowing. Next is the IOCT-guided bleb-sparing epithelial exchange. So bleb-sparing epithelial exchange is actually a bleb reconstruction surgery wherein we remove the tissue showing an abnormality, that is the epithelium over the bleb, along with advancement of the surrounding normal conjunctiva without any manipulation of the bleb itself. There is a difficulty in, however, we have a difficulty in peeling the epithelium in few patients, especially where there are very big thin cystic areas with multiple thin cystic areas in between, and we have to peel these in multiple segments to avoid inadvertent damage to the underlying bleb structure. Therefore, IOCT in adjunct with trypan dye is used to ensure a complete bleb epithelium peeling, because there is a direct visualization without causing any inadvertent damage to the underlying functional bleb structure, which is actually very thin and flimsy. And since we are preserving the underlying bleb per se, the overall long-term outcomes of the bleb of the bleb itself is very good in our hands. So this is how the thin cystic avascular bleb looks like at the baseline. You can see the IOCT. It is a big overhanging bleb. And here we have stained the epithelium and we have dissected it all along the edges. And at the end, we have advanced the conjunctiva. We can see that now the bleb is being covered with a healthy conjunctiva, and the bleb size itself has reduced much, and therefore this dysesthesia of the patient as well has improved. This is the small video clip of the IOCT-guided bleb sparing epithelial exchange. So this is how we can see a big area of thin cystic avascular blebs. And these blebs are nowadays lesser. We don't tend to see these blebs because nowadays we are using lesser doses of MMC. And these are the previous blebs operated nearly 10, 15 years ago, wherein the doses of MMC were used for 0.04%. And now we are staining the epithelium with the trypan blue dye. As we can see that the trypan blue dye stains the epithelium lightly as it stains the anterior capsule while doing the cataract surgery. Therefore, we have to thereafter we have to very carefully dissect the epithelium at the edges of the bleb. So this is the IOCT. We can see how big overhanging bleb it is, causing dysesthesia and causing ocular surface impairment to the patient. Patient had dry due to this reason. So after this, we can see that we are gently peeling off the epithelium, and we are being very careful while dissecting the epithelium, because if we go slightly deeper, or if we are a bit rash in cutting the epithelium, you can directly damage the bare bleb which is just beneath it. And as we are peeling off the epithelium, we can see directly in the OCT that the epithelium is being peeled off and the underlying bleb is far away, and thereafter we are putting our scissors and cutting anteriorly. And this is the most tedious part of the surgery and the most time-taking part of the surgery, especially the bleb peeling. And after the advancement, after the introduction of IOCT, the IOCT guidance prevents damage to the underlying tissue, and our complication rates is next to zero now. We have not ever happened that the underlying bleb structure has ruptured while using OCT along with the bleb surgery. So this is the preoperative bleb CP, and this is the ASOCT. And post-operatively, we can see now the bleb looks like an ideal bleb, and on the ASOCT also the bleb is well circumscribed. It is a functioning bleb with multiple hyporeflective, multiple microcystic spaces. Then we also do the IOCT guided transconjunctival suturing. So intraoperative OCT, the intraoperative OCT helps to get the exact location of the scleral flap while performing the transconjunctival surgery. So we have come across a few cases. Now we have a series now wherein these high-risk patients who were myopic, especially myopic patients. This one is particularly a case of a myopic patient with uveitic secondary glaucoma, and we went ahead and did a trabeculectomy. However, in the immediate postoperative period, his pressures did not rise beyond 4 millimeters of mercury, even after doing conservative management. So, and also the patient complained of reduction in his BCVA, which reduced from 612 to 3/60. And on doing on a macular OCT, we could see folds over the macula suggestive of hypotenuse maculopathy. So this patient had to be intervened, and nearly it was 4 weeks, and reopening the conjunctiva and resuturing the flap is basically a nightmare both for the surgeon and the patient, because this leads to a lot of fibrosis, and we are dead sure that our surgery will fail. And since it is a young male who is uveitic glaucoma, we had to do something. So we planned for a IOCT guided transconjunctival suturings, wherein we are suturing the scleral flap transconjunctively with minimal anesthesia. So we had given very minimal anesthesia and with the topical proparacaine, and performed the surgery. And we can see that preoperatively there was an overhanging cystic bleb. You can see how big cysts are there, and post-operatively, as we put multiple sutures, we can see these cystic spaces has reduced. Actually, the scleral flap has been closed, so therefore the flow is reduced, and therefore these cystic spaces has reduced. So this is a small video clip wherein we are showing a IOCT guided transconjunctival suturing. So we have already, as you can note, we have already placed 3 sutures, and now we are doing a transconjunctival suture using a 10-0 nylon. So without the IOCT, what we had done, we had also done it in patients without using IOCT, but what we had difficulty was that because these blebs are overhanging, they're overfiltering, we cannot see the underlying bleb structure, and patients usually are uncooperative in these these patients are usually uncooperative even after giving a bleb. So we wanted to be doubly sure that and this was achieved by using an IOCT, and we can see that as we are passing the needle, we can see the depth that it is going to the scleral flap. It is not superficial, and with minimal anesthesia, which actually is minimally less complicating, we have sutured our scleral flap transconjunctively, and we have put nearly 4 sutures because this was a very overhanging bleb, 4 to 6 sutures. And however, on the post-operative day one, uh, the pressures were 30 millimeters of mercury, and we did a selective removal of or alternate removal of the sutures over 1 week, and thereafter I think 2 sutures are still buried, and it's nearly 3 months now. The pressures have built up to 10 to 12 millimeters of mercury, and has been maintained till now without any other medication or any other intervention. So this is a life-saving surgery both for the patient as well as the surgeon, especially in young patients who are in whom the visual acuity, maintenance of the visual acuity is very important. Then we have the IOCT guided bang cleft visualization. So this I will show you. So this is IOCT guided bang cleft visualization. So after doing a bang, we have stripped off the epithelium, and especially in the beginning cases, we want to be doubly sure that have we actually stripped it off, or we have just incised and come. So it is actually a goniectomy where we have to strip off the trabecular meshwork. So if you can see here, there is a dimple on the IOCT. This dimple means that there is a defect has been made, which was not there preoperatively, and this is this again we can see that the stripping, after the stripping we do the IOCT. So this is the dimple that we see intraoperatively, and we confirm that the strip is removed in toto. Sometimes it does happen, especially when it is our initial cases or learning cases, that we just incise it or it has been partially stripped. So we can just scan with the IOCT that it is consistent through the 3 clock hours, and we can perform in the post-operative day 2, we confirmed our findings and performed a high resolution swept source OCT, and we can confirm that same dimple is there post-operatively. Then we have the IOCT guided AGV tube positioning. This is very important, especially when there is a corneal opacity. So these are very useful in cases. This is a case wherein it is a case of pediatric glaucoma, which had multiple failed trabeculectomy and cyclodestructive procedure, and the patient had a corneal opacity as well. So tube was the only option. However, we were skeptical as to how to put the tube because there's a corneal opacity. So then we thought, why not use the IOCT, because we have used in so many cases. So here we are inserting the tube. So since we have done multiple surgeries, we know in which direction we have to go. So here the tube is going, and we have made it to go down towards the iris rather than towards the cornea. And once we are sure that it is more towards the iris and not the cornea, then we completed the surgery. So this is another IOCT guided AGV tube positioning. This is the technique where there was a lot of limbal scarring, and also in cases where we don't have a donor scleral tissue, we use the scleral tunnel technique. So in the scleral tunnel technique, while doing it, this tunnel should be long enough. It can't be like a 2 mm flap that we had made, because we don't have didn't have a scleral donor tissue. And however, and we were putting it in the sulcus. The only problem was that with a lot of manipulation, and a lot of pigment dusting along with viscoelastic in the anterior chamber, we could not clearly see that our tube was put in the sulcus or it was anterior. So that is why we did a IOCT. We confirmed our finding using the IOCT, and we can see that the tube is well placed. It is not touching the endothelium. It is merged towards the iris, and we left the tube. And on the post-operative day 1, the tube was well positioned. So this is IOCT is actually like a third surgeon. It's like a bird's eye view, or like a commentator's or the umpire's view, when a third person is there who is experienced enough, who tells you that no, it is in the not in the right plane, it is in the right plane, and then we are confident and we can close the surgery. Because some few surgeries, especially the pediatric ones, we are doing under general anesthesia, and that cannot be given every time. So we have to be very sure before closing our surgery. Lastly, the OCT guided aqueous angiography. So this is a new tool that has come up. And it is a real-time aqueous humor outflow imaging technique performed under the physiologic intraocular pressure. And angiography is performed in the operation theater under supine position. So we modify the existing OCT and we use the flex module. This is the flex module. This is the aqueous angiography picture. And I will take you through a small video also. So this is the study that we had done in our center, wherein the aqueous angiography guided ab interno surgery, that is the bang surgery, was done for open angle glaucoma, and we had seen pre-bang and post-bang aqueous outflow. So our question is that whether bang improves the aqueous outflow. So this is the baseline aqueous outflow. We can see that the nasal collector channels, and post-operatively we can see how the outflow has increased, meaning that the bang is actually improving the outflow. However, we need long-term studies as on to how effective this study is, this procedure is. So this is a small video of the ICG aqueous angiography guided mix. So we can see that temporally we have injected the dye, and nasally we can see the nasal channels filling up. Then we can see inferior channels also and superior channels also. Temporally, very minimal channels are being filled up. Then we perform the bang surgery, and we are stripping off the epithelium. We have taken the bent needle. We've stripped off the epithelium. Now we have again injected the ICG dye 0.5%, and we can see that the channels, the nasal channels, the outflow has improvised a lot post bang, especially nasally, with respect and versus the inferior and temporal ones. Thereafter, we do a INA and close the surgery like a routine phacoemulsification that is being done. So to conclude, I would like to say that IOCT with heads-up display allows rapid visualization of the area of interest and provides the surgeon with information regarding tissue surroundings and instrument tissue interaction. Because of its finer resolution, OCT is able to present detailed view of the bleb wall, sclera, and an accurate assessment of the location and extent of the bleb structure. This permits better visualization, easy maneuvering, and better dissection, and thereby reducing the risk of complications. Also, the OCT enhanced aqueous angiography is a future research tool and has much to gain, and has much to open up or much to reveal, especially regarding the mixed procedures, whether they are actually effective or not. And thank you for your patient listening. I'm available on the below email for any queries. Thank you once again.